All right. Hello, everyone. It is so nice to be joining everyone on Sunday as part of our NBC Sunday series, started in partnership with Abigail Johnston and the late Allison Teschler, where we came together and we really wanted to bring to the forefront topics that are pertinent to those living with metastatic disease, because we know that there are just unique questions, unique needs, and things we really just wanted to address as a community. So we are excited to be kicking off 2022 with Amy, who is joining us today, where we're going to take a deep dive on the topic around radiation and some of the nuances between radiation oncology, radiation diagnostics, et cetera. I think sometimes the terms can be a little confusing to understand all around. But what I would love to do before we dive into today's topic is really just provide some context and personal introductions, because I think it's always really great when our viewers and listeners have a sense of a little bit of who we are. So for those of you who don't know me, I'm Laura Carfing. I am the founder of Surviving Breast Cancer, a nonprofit organization that provides education, community, and support services to those diagnosed with breast cancer, their caregivers, and their families. I personally was diagnosed at the age of 34 with stage 2B breast cancer. It did have lymph node involvement, so I did have a full axillary node dissection. And I ended up being triple positive, which means that I am going to be on hormonal therapies for probably the next 10 years or so. But outside of that, we are just taking it one day at a time. And honestly, it's one of those things when you have to take this pill every day, you're constantly reminded that you still are living with a breast cancer diagnosis, whether you're stage 0 or stage 4. Though I understand that there's definitely some nuances within those spectrums as well. But that's a little bit about my background. Amy, I'm so glad to have you today on our NBC webinar series, on our live stream, and also what's going to eventually be ending up on our podcast, Breast Cancer Conversations. So if you'd like to introduce yourself.
I am Amy. I am from Georgia, but I currently live in New York. I've been here 20 years. My background is in diagnostic imaging, which covers from radiation to MRI, all the different various tests. We interact. We're actually kind of like the center of the hospital for all patients. So you come in, and most of the time you've got to get some type of testing to get answers if you have any kind of clinical diagnosis, whether it be cancer or not cancer. I was first diagnosed in January 29th, 2014 with breast cancer. And at the time we thought it was like 2A, but then with surgery, we chose a route of double mastectomy. And during surgery, they found lymph node involvement, and my diagnosis soon switched to 3B. And I ended up having cancer in both breasts. I have lobular. That's my history and background. I'm hormone positive and HER2 negative. And then 5 years to the day in 2019, I was diagnosed metastatic, had one lesion on the spine. Same type of cancer, but a little bit different. Mine kind of went around the hormone blocker that I was on. And so now I'm more ER positive and less PR positive. My numbers changed a little bit. And so far, I'm about 37 months outside of the metastatic diagnosis, and I'm still on my first line of treatment. But, I'm like everybody else in the metastatic community. You wait for the other shoe to drop, You hope it doesn't, but, that's kind of living. That's how it works.
I know, kind of on this like every 3-month and timeline, right? And seeing if it's working, is it still working? You bring up so many great points just in your introduction. Speaking of lobular breast cancer, can you explain a little bit more about what lobular is?
Lobular is generally found in the fatty tissue of the breast, and it spreads a little differently. It normally goes to bones first, but with the lobular diagnosis, that's rare. It's like less than 10% of the community, and most of the time it's just in one breast, not in both breasts. So it's one that I think it evolves and we learn about it as we go. But most of the people that I interact with, they're ductal and not lobular. So, even though we're all in the same community, we're on just a little bit different journey.
Oh, absolutely. There's so many nuances, subtypes. I learned all of that once I got diagnosed, that it's not just this big umbrella of breast cancer, but there's so many segments of that, grade, type, the intrinsic subtypes, the hormone receptors, etc. And bringing up the fact that you were on a hormone blocker, were you on tamoxifen or on one of the aromatase inhibitors?
So that's where we get a little tricky too. I had something that was suspicious on the ovaries when I first started chemo. So I opted, when I got done with the IV chemo that first year, we wanted to have a hysterectomy. So I saw a specialist and they took out my ovaries. So I ended up being on oh my goodness, the name slips me. Not tamoxifen. I was on postmenopausal, even though I was diagnosed at 39,
Mm,
because I chose to do surgical menopause.
yes. Okay. And I'm similar. I didn't go through the surgery piece, but I'm on letrozole, actually, one of the aromatase inhibitors.
So I started on letrozole and then I switched to anastrozole. And then I ended up going back and forth between the two because I had some side effects. Did you ever have like the joint pain and
Still
some
do.
of that stuff? Yeah.
Yeah, I tried some different ones as well, and it's kind of like picking the best of all the evils, I guess.
Right.
Still just dealing with it, a lot of Epsom salt baths. So, but absolutely, and again, being premenopausal myself, I have not opted for the surgery just yet, but I am getting a Lupron shot, which suppresses the functions of the ovary. So it does kind of put you into this medical menopause, I call it.
Yeah.
So, ugh, well, great stories to share. So for those listening, whether you're relating to some of this or all of this or one or the other, I think it's just really great to hear the different experiences and how people are responding to their diagnosis, their treatments, and the decisions that they make. So
We
let's
have to remember all of us are individual. I think that's the big thing. Like you can take what other people bring to you and be your own advocate or research yourself, but we have to remember that every one of our journeys are just a little different.
absolutely. Yeah. What do they say? Like not two tumors are identical, right? They're all
Right.
separate. Exactly. And I'm still learning that even being diagnosed about 5 years ago, the treatments that I had were the best treatments and opportunities at the time and how much the science has advanced. I was just talking to another woman. I was on Cytoxin was one of my IV chemotherapies. She's now taking Cytoxin in an oral pill form. And I'm like,
Yeah.
oh, how much more convenient would that have been? So, we're always constantly learning too. So let's dive into a little bit of today's topic, which is on radiation, radiology technology, the technician, diagnostics. Can you give us just a high level overview on maybe just some of the nomenclatures, the language around what radiation or radiation tech is versus the radiation oncology piece, just so we understand like the framework that we're discussing today?
Okay, so the technologists in the radiology department, they're either like a diagnostic tech or they could be a nuclear tech or an ultrasound tech. And then on the oncology side, they went to radiology school too, but they pursued a little bit further education. So then they go to diagnostic school. Most of us start out as a diagnostic tech. It used to be a 2-year program through a hospital. Now it's like 4 years and it's through a college. You have to do clinical hours similar to nursing. But we go and we take classes, and then you start out as an x-ray tech. And then once you do that, you can specialize in CT or MR. You can go back and do nuclear. Ultrasound, they go to a separate school and they go just to ultrasound school. Most of those techs now, they go for a couple of years and they come and then they eventually get their 4-year degree. But for ultrasound, for each body part, they take a different registry. For a diagnostic tech, if you do CT, then you take a test for CT to get your license there. For MRI, the same thing. And you can specialize like in interventional radiology. So everything, there's schooling and there's on-the-job training and clinical hours.
Wow. And is this your profession, one of the streams that you went through personally?
Yes. So it's funny that I'm in radiology. I had scoliosis as a small child, so I used to get x-rays regularly. So I knew I wanted to do something in the medical field. I always thought it would be cool to be the person to say, hold your breath, breathe, So,
That voice,
so
that ominous
yeah,
voice in the CT
yes,
scan.
yes. So I always thought that that would be kind of cool. So I applied to radiology school. I did a hospital-based program about 22 years ago, and then I pursued my bachelor's, and then I finished my master's last year after my metastatic diagnosis. I had just started my master's when I got diagnosed, and I'm like, I have to finish.
Yes,
Yeah.
absolutely. And I'm sure you learned so much on both ends going through it personally and then the textbook side and the clinical piece as well.
Yeah, you know what I've learned, I think, is sometimes we forget as techs that it's your test that's going to make a difference. You know what I mean? We're doing 20 or 30 a day, but you're there and that's your one test, and it's going to change the outcome of it could change the outcome of your treatment or let you know you're safe. So just think it's a reminder that we need to treat each patient like as a patient, not a number.
Yes. And I remind myself that of that too when I go into these appointments. You're absolutely right. Like, we want these people to be part of our care team because for us it's like this is the one day I'm going in for a scan or a follow-up. But then you're absolutely right. These people are seeing, 30 patients a day potentially, sometimes more. Um, and then at the end of the day, they're going home to their own families because this is their profession as well. So, having that level of empathy and understanding and partnership, I think is really important, especially in this field.
Yeah, and I think when as a patient, when you go, you got to tell them if you're nervous or we know our bodies. We're stuck for blood work on a routine basis. You know if that's going to work or not work. And as technologists, we have to remember if a patient tells us they know their body better than we do, right? So we have to
Mhm.
listen. And I think the other thing is we need to make sure we're explaining the preps for the different exams. And I
Mm,
think sometimes, as a patient, your doctor tells you you're going for the test, but if it's the first time, you might not know what it entails.
yes, absolutely. That's so important. Can you give me an example of some of the prep and what's involved in the diagnostics?
Okay, so a lot of times when we look at abdominal imaging, because we're looking at the liver and the stomach, they'll have you fast. And it's because if you're having a CAT scan, you might be drinking oral contrast. If you're having an ultrasound, they might have you fasting so that they can see the anatomy better, so that stuff is not blocked. For MRI, they have you fast to make sure that they can see all the structures. Sometimes you don't have to fast if we're scanning your brain. You don't have to fast because we can see that. But if they ask you to fast, it could be that the contrast they're going to give you, injection or oral, could make you a little nauseated. So they're having you fast to try to curb some of those side effects.
Yeah, absolutely. And is it like a 12-hour or 24-hour fast usually, or does it depend?
It depends on what they're looking for. Sometimes they'll tell you don't eat or drink anything after midnight. You
Mm,
could have a few sips of water when you're fasting if it's not for surgery or whatever. That's the fast is more or less taken in sugar or the calories for that.
I
For
see.
PET CT, they do have you fast longer, and that's a little different because they're injecting you with the radioactivity.
Mhm.
So that's why.
Yeah. And I'm always curious about what they inject you with. So they inject you for those CT and MRI scans and PET scans with a radioactive dye that is, in theory, is my understanding that it lights things up if there's like microbolic, no, metabolic
So
activity.
metabolic activity. So
There you
for the PET CT, they inject you with a radioactive tracer. For the bone scan, a radioactivity, and those things go to certain types of the body, and that's how they scan you. For CT, they're injecting you with a non-iodinated contrast, but that contrast, it lets us see the blood vessels. It lets us see if there's a tumor in there. If the tumor takes on the contrast, that means there's blood feeding the area. In MRI, it's a little different. It's a natural element. We use like a gadolinium based product. There's no radioactivity in that. MRI uses radio waves. It's a magnetic field, and it works off of the water in your body. The noises you hear is when you get into the machine, all of the atoms in your body align with the magnetic field, and those noises you hear are the machine sending signals and gathering data off of the water and the tissue in your body. So,
Wow, I'm so glad you broke that down because all I can hear is the like the
yeah.
babies. Noise.
So, yes. And so a lot of people think that's radioactive. It's not. But MRI is not always your go-to, because MRI, we do dedicated areas, whereas in CAT scan, they can do a large amount of the body in just a few seconds. Like they can do from your chest to your pelvis in less than 10 seconds. So then they get a big overview. So that's where you start there. And then when you get, like, they'll say, hey, I need you to go for a liver MRI. That's dedicated. Then we're just doing images of the liver, whereas the CAT scan looked at the lungs, the bones, and all the other organs in the digestive system.
Really good point. And that's something I would love to linger on a little bit more.
Okay.
I understand that, the MRI, the CT scan, and the PET scans are all three different modalities. Are you able to kind of break that down for us a little bit and explain some of the differences? Because I feel like sometimes we use them interchangeably, but they're actually three separate types of technology being used for different outcomes, correct?
Yes. So, like with the CAT scan, if you go to the ER and you're sick, a lot of times they'll send you for a CAT scan. That's so they can see a large area. It does use radiation, it's minimal. It's like background radiation. If you have them over and over and over again, then yeah, you are being exposed. That's why they try to spread them out.
Okay.
The CAT scan, a lot of times in the breast cancer community, we're doing like a CAT scan for the chest, abdomen, and pelvis. And then what we're doing is, if you drink oral contrast, the oral contrast fills your digestive tract, and it allows us to look at everything, the organs, the lungs, and the digestive tract. Without the oral contrast, they can see it, but not as well, because the way everything's wound into the abdomen and pelvis. And then for PET CT, that's a little more dedicated. You go in and you're injected with the radioactive tracer. It's dependent upon your blood sugar. You don't want to have a high blood sugar for that. That's one of the reasons why they tell you to fast, watch what you eat the week before you go. You don't want abnormal results. So for that one, they ask you not to be physically active the day before,
Mhm.
like, because if you have a strain or something, it could make something look hot, is what they consider like a high uptake, and it might not really be something there. But the PET CT, what they do is they scan you in CAT scan, and then they'll do the PET CT, which is a nuclear study, and then that's what's masked over the CAT scan, and then that lets them know where if you have abnormal activity, where it's over, like if it's over the thyroid or over the liver or the kidneys.
Mhm.
And then for MRI is a little more dedicated. MRI, it uses, like I said, it doesn't use radiation. It uses the water that's in the tissue in your body. But in MRI, it has to be a dedicated study. You can't go in there and get your head, your neck, and your entire spine, because each body part takes anywhere from 30 minutes to an hour to scan, depending on what they're looking at. And it's a long time to lay there, and it's very sensitive to motion.
Yeah, thank you for that overview. So much information to digest. I feel like round two, we might have to meet in person and you walk us through the actual hospital settings and some examples of all of this, because it could be really scary for someone at their very first time to go in and have these scans. And, even having to deal with some, not just the anxiety, but I know myself too, get really claustrophobic. So needing to be absolutely still and lying down and going into some of these kind of close quarters, so to speak, there's a lot of emotions I think that bubble up.
I do, because I think it's a reminder of what you're living day to day too. But it happens, just so you know, it happens in a normal setting too, or in a community. When somebody comes in and they're not certain of what we're checking or whatever, and I think it comes from being informed. I don't think the doctor always explains what you're going to walk into either, and I
Mm.
think that's somewhere that I want to advocate, that we need to explain or let the patients know what they're walking into.
Right, exactly. Do you know why you're here? Do you know what we're testing?
Yeah.
How the process is? And then when they're going to find out their results too. Is it going to be in 24 to 48 hours, or is it going to be 2 weeks before you guys can get a read on all of that? I think just having some sort of time frame is also equally important.
Well, recently they passed a law where now if you have like my chart at your medical facility, used to your doctor could hold your results, but now your results are immediately available to you once the radiologists have looked at them.
Oh, wow. I didn't know that. Excellent. And is there any fear with results being posted without the context of a doctor providing context to the
I
results?
think there is, but I also think we need better access as a patient to our information. HIPAA works when it works to keep your information from going somewhere, but it's also a challenge too. Say I go somewhere and get one test and then I end up somewhere else emergently trying to get my information, because if the right documents aren't signed, you can't get that information sent.
Yeah, no,
So,
absolutely. I totally agree. I think sometimes having the more information, the better, sooner the better. We can have those follow-up calls afterwards.
yeah,
I just feel like they always come in on like a Friday at 5, right when everyone goes home.
right.
So one of the questions that I'm noticing from one of our online members, they're asking, and I hear this a lot with regards to the contrast being accessed through the port versus the just IV. And there seems to be a lot of reluctancy around utilizing the port for the contrast for these types of imaging.
Okay.
Can you tell me a
So,
little bit about that?
yeah. So the one reason they try to stay away from using your port is you have to be trained to access the port. So not every nurse or provider is trained. But the other thing is, if the contrast is not flushed out, it could cause issues with your port, and then your port doesn't work appropriately. That contrast could clog up your port. They
Mm.
do use it. Like I'm one of those, I'm a very hard stick. So I beg for my port to be used. But the other thing with certain exams, we prefer to do it in your arm, especially if you're having something vascular done. The way it comes into the heart and then is dispersed, it's better for us if we're using your arm. There's not like a bright spot of contrast right where the port is in the chest. I don't know if that answers the caller's
Yeah.
question.
Yeah. No, I mean, I think that's a good point too, because now that I'm thinking about it, I always had to go in the hospital to a separate area to get the port accessed versus just the regular phlebotomy place where you type your name into the little computer screen and they hook you up with the IV. And I think part of it too is just like how many times do we need to be pricked and where they're accessing it and all of that. Like if we could just eliminate one option, I would say that's a win for us.
Right.
Yes.
They do now use ultrasound guided stuff to start a line. And our bodies have been through so much, especially if you've had IV chemo. So
Mm.
if you know you're a hard stick, I encourage you to like make them aware, let them know what works. Like be vocal about what works for you. And if you find resistance, you can always ask for somebody that's a supervisor or something else. It's about how we go about asking.
Really good point. Great information. So I also feel like this is a great opportunity to kind of like go behind the scenes and ask, since you are on the tech side, I'm always wondering, like when we go in for scans or any sort of diagnostics or even just regular follow up, because sometimes that's where they discover things also, unfortunately. I have this new saying where you go to the hospital to get sick because, they're always going to find something for you. But out of curiosity, I'm always trying to read the facial expressions of those people who are administering these types of scans. Can you speak a little bit to like what's going on in your mind when you're seeing patients who have cancer or coming through, are concerned about progression? Is the treatment working? How how does the body language and the bedside manner, so to speak, play out in those situations?
We're trained and we really try hard not to give the diagnosis right there at bedside, because that's not our place. It's technically the radiologist or your doctor to share. But oftentimes the tech does know when they're scanning. If you've scanned and they're seasoned, they know when they see something on the images that there's going to either be further testing or whatever. I mean, we see a lot of stuff. I've been scanning over 20 years. So a lot of times I know when I see something. And then for me, it's gut wrenching because I'm like, oh my goodness, if they're not diagnosed, I know they're going to hear the words. And if they are diagnosed, I'm gut wrenched too, because I know what that's like when you're waiting to see if it's positive or negative or whatever. So
Yeah.
some days, like I feel like I chose a career where I don't feel like I work. I love what I do. So for me, oftentimes I feel like I'm living my passion. But at the same time, when I have like, I might go a couple of days, I don't scan as much anymore. I help train and I oversee the department, but I do work part time so I can still get the patient interaction. But some days it's hard when you scan somebody and they have no clue, especially if they come in and they've been sick and just lost weight. And then you're like, oh no, they don't even have an idea.
Yeah, exactly. We met a dear friend at the San Antonio Breast Cancer Symposium this December. Abigail and I went in person because we were just clamoring to see people in person post COVID, and she was so proud that she lost weight, like she was on a diet. And our first reaction was like, was it intentional? Because you never know in our community. You're like, were you trying to lose weight? Or are you
Right.
whatnot? So, trying to just bring humor and light to like the realities that we're living in for sure. So one of the topics that we wanted to talk about today also was how we can partner with our radiation techs as part of our medical care team. I don't know if you have specific advice for just the general population or those specifically living with metastatic disease that you could share with our community.
So I would say if you have a question, ask the question. If they make you feel rushed, like you're their priority. Yes, they might be busy. Take the time to ask a question. Make sure that if you think they did something good, tell them, like share with them what worked for you or what didn't. Many of us have had breast surgery, so you can't lift your arms or whatever. If they tell you you have to, the reason they're trying to get you to lift your arms is to move them out of the way to get better images. But if you can't, the test can still be done. So just remember there's more than one way to do something. And even though they're the tech and they're doing it, it doesn't mean that we're always right. I think that's the thing we have to focus on. Yes, that's our job and our expertise. So when we're explaining, you're trying to be helpful, but I also think we have to take the time to hear our patient too.
Yeah, absolutely. I really appreciate you sharing that. And it's a two-way conversation. I remember just going in for an annual mammogram. I had a lumpectomy, and so I'm still getting mammograms. And obviously that hurts because there's so much scar tissue still left and everything. And I remember the woman on my way out was like, good luck with everything. And I'm like, good luck because it's the rest of the day. Good luck because she knows what's going to happen. I was reading so much into like, what do you mean good luck? Do I need luck? So I think we're always looking for kind of reading in between the lines to understand what is happening. But to your point, I didn't want to leave the rest of my day like that. So I actually asked her, like, I'm sure you're just saying that because you say that to everybody, like, have a great day, best of luck, etc. But just not letting myself walk out the door feeling that level of anxiety and concern. So whether it's beforehand in positioning or afterwards, to really have those conversations with your team members. So I appreciate that.
So that's what brings me to a thing. I used to always say, I'm coming in to get you off the table and you're free to leave. But then I was scanning inmates. So I was telling the inmates, you're free to leave, and they're not really free to leave. But it's to your point, good luck. I think we're just trying to say something that's positive.
Yes.
And good luck in our world. I mean, I guess as a tech, it really doesn't mean the same as it does being a patient, right? So
Mm-hmm.
if it's said to you, maybe bring it to their attention because you're probably not the only person feeling that.
Yes. Yes. Good point there too, with like the lexicon and the language
Yeah.
really matter. Absolutely. Now, have you noticed a difference in your personal practice and profession in this work since your diagnosis?
I feel like I've always tried to treat patients, but I've been a patient since I was a child. So I feel like I'm a little different. I do feel like I'm more patient with some things than I was before because I didn't understand the anxiety with the scan, treat, and repeat. But
Mm-hmm.
that part I'm better with. But then there's days when I'm not better. When somebody comes in and they're not really hurt and they act as if they are, then I'm a little frustrated because I'm like, there's other people out there living, you know what I mean, that come in there and they're different with us too.
Oh, yes, definitely. Oh, it's so hard. You never know who's going to show up on your roster that day, right? Who you're
Right.
going to be seeing.
For
Oh.
sure.
What other questions or advice do you have during this conversation? I mean, you've been so thorough talking about the different types of scans,
Well,
addressing.
we didn't discuss mammo, so we can discuss mammography for a minute. The reason that the mammo sometimes hurt, it shouldn't like leave you bruised and stuff, but they have to have a certain amount of compression to be able to get the breast tissue displayed appropriately. Many places now have 3D, so that overreads too. But it's super important that if you go somewhere, make sure you bring outside images so you have a comparison. Another thing to remember is if your scan says this month it's 0.5 centimeters by 1 centimeter, and then in 3 months it says 0.7 centimeters and 1 centimeter, if two separate people read it, it could be the exact same measurement, but each of our eyes are a little different. So we might measure it a little different. It's when
Mhm.
you have extreme growth. So if you see a report and there's minor changes, don't get excited yet. Go back to the oncologist and talk to them or ask for overread. We discuss this a lot on our Monday night group. The ladies will get something and they don't understand or whatever. You can always ask for an addendum or a second look or even a second opinion. So that's something to make sure that you're aware that you have the option for.
I did not know that. That's really helpful to know. And does the breast density play a role in this? I know we're talking about mammography, but
Yes.
really trying to go and advocate for whether it's an ultrasound or an MRI if the tissue is really dense.
Yes. So some places the practice used to be that if you had dense breast tissue and they were watching, they would do a mammography, and then 6 months later they would do an MRI. An MRI is very detailed. It does some 3D imaging. You get about 3,000 images with that, but it also shows the nodes under the arm sometimes. Where mammo, they might see them, but only if they're calcified.
Mm,
I think what it's important to remember is make sure you're doing your follow-up testing. Like if they say get one, it's one thing if you missed a month or whatever, but don't like skip.
right.
Keep up with your testing.
Yeah. No, we keep advocating for that too because I know a lot of people during COVID were nervous to come in or even having appointments canceled, etc. But really trying to get people to keep those appointments and all of that.
The
So,
other thing is we talked about the technologists, but it's important for everyone to know that radiologists are trained too. They can read general radiology, most of them read x-rays and stuff, but a lot of times somebody specialized will read the PET CT or the MRI, and they don't just read like an MRI. You have like a neuroradiologist, which is like neurological stuff, the brain and the spine, and you have musculoskeletal. That a different rad will read those, but they also ask each other to help. Like if someone's on call, sometimes the delay in getting your report is because they're covering the ED as well. So it might take a day or two, but generally it shouldn't take them more than a day or two to read unless the specialist is off. That would be where the delay would be.
yeah, good insight to kind of know what's going on behind the scenes. And it's not always bad news that we're waiting on.
Right.
Yes. And so how are you doing now? What's if we can talk about maybe some of your personal experiences, the type of scans that you're getting and how you're doing with your treatment?
So since I'm lobular, I'm generally a CAT scan and a bone scan. This next round of scans, I'm going to get a PET scan, but I haven't had a PET scan in like 2 years because the lobular, that's not necessarily the gold standard just because of how mine spreads and other things. But I have been doing well. But with every twinge or pain, like I get nervous too. I'm just like the
Right.
average person, even though I'm there, I have anxiety about going, even though I perform those tests daily. It's different when you lay down on that table versus when you're helping somebody with the scan.
100%. And you mentioned that you identified the progression when it became metastatic due to a lesion on your spine. What type of symptoms did you have? Was it back pain that you went in for, or was it
I
a
did.
random test?
So I had some back pain, and then my tumor markers, they just moved minutely. My doctor uses some of the blood work markers like the CA 123 and stuff. She does some of those blood work, but it moved just a little bit, and I had a little bit of pain. So I went in and I had like a CAT scan, and then I had a scope, and I was okay. And then over the next month, if I stood for a long period of time, I felt pressure. So then I went in and had a chest, abdomen, and pelvis CAT scan, and then they saw the lesion, and then I had to have a bone biopsy. And then, I'm just like everybody else in the waiting game where you have one test and then you wait a couple of weeks and then you have something else and then you wait a couple of weeks.
Yeah.
So,
but you're in your first line of treatment, and
yep.
what are you on right now?
I'm on Ibrance, and then I do the Faslodex injections. I wish they could make those oral. So I do Ibrance and Faslodex. I started out on 125, but my blood work, my white count stayed down. So, and then my ANC stayed slow. So now I'm on 100 of Ibrance. One of those things when it's working, you don't want to change or adjust your dose, but I didn't have any choice due to the blood work.
Sure. No, that's interesting. My doctor, my primary care now is just refers to me as like, you're just a special case all the time. I remember going in for a persistent cough. Again, it could be allergies. It was COVID. It was just a persistent cough. And instead of just like prescribing, the cough syrup or cough medicine, he was like, we're just going to go and have you have a chest x-ray. And I'm like, really? Like that serious? I didn't know you go from like 0 to 100. But again, just because I think she wants to be proactive with absolutely everything. And I'm not worried, knock on wood, but even tomorrow I'll share with the community. I'm going to see a liver specialist as well because there was some uptake in enzymes in my liver. So, just one of those things where I just keep telling myself, it is what it is. I'm the special case. They'll just refer me to the specialist all the time now. That's just part of the practice. And we just hope for the best. So,
but some of your liver enzymes, isn't it because the amount of, how long have you been on treatment? Because the treatment affects your liver.
It does. And so that's actually what I'm interested in talking to him about. So I've been on the aromatase inhibitor and the Lupron shot now since 2018. So 18, 19, 20, almost 5 years.
Right.
Plus the number of chemotherapies that I was on prior to is just like, the proactive try and kill everything process. So I'm sure my liver is a little angry about all the toxins that are in my body. So we'll find out more about that tomorrow.
So are you nervous or you're not nervous?
Right now I'm not nervous because I'm just like, gosh, I have to take off work and now I have to go there and find parking. Like my head is kind of like wrapped around about the annoying piece of it. But I'm sure after having the conversation with the doctor and how that conversation goes, we'll see.
Best of luck to you. I hope it's nothing.
Thank
I
you.
mean, and then this is crazy because I don't think that's one thing I don't think they tell us as a community. You learn it as you meet the other women. It's all the side effects, or as they, what they call them. But it's just crazy what it does to everything else in your body.
Yeah. So have you experienced or heard of other women who have developed like fatty liver because of the toxicity of treatment that they're on?
I live it. So I live it, but yeah. So I've tried different diets. That doesn't matter. I've tried other things. My numbers, sometimes they're up, sometimes they're down, but I have a very fatty liver. And it's from all the treatment and stuff.
Yeah.
I did ACT is what I did for my IV chemo, and it was like 8 months long. Like I did dose stints. And then right after I got out of that, I had to do bilateral chest radiation. So I think that did it too. It was like a year of treatment.
Yeah. And speaking of that, with the I call 2017 my treatment year, and then 2018 is when I'm on like the maintenance drugs. But even you were mentioning with the radiation too, the toxicity to the heart. I've added a cardiologist oncologist into my back pocket now too. Again, just to be proactive with the longer term side effects of the treatments that we're on.
So. Yeah, and I live somewhere I can get into the city, but my oncologist came from Sloan and she's in our area, which is like 70 miles north of the city. But I think about it, what about the women that are in the rural communities that don't have the same resources or know what questions to ask? They don't even know who to go to. So I hope like as I advocate, I'm able to figure out how to reach the smaller little communities.
Absolutely. And, with people online and just having conversations like this is helpful. We can definitely partner. I'm putting together FAQs, things that we can share, getting out to even just some of the general practices, because again, a lot of times in these rural communities, they don't have a breast cancer specialist oncologist. The oncologist might be overlooking 2 or 3 different types of cancers, et cetera.
Right.
So definitely more than happy to help work with you on that and and get the information where it's needed.
I look forward to that.
Yeah.
Definitely.
Well, thank you all so much. This has been wonderful. I know this isn't like live per se, but I'm just looking through the questions. There's a lot of people on social media, so I appreciate all of you guys commenting and resonating with our conversation today. As I mentioned earlier, we're going to be continuing with our kind of like every other Sunday series where we're going to be bringing on experts who are either living with metastatic disease or treat those who are living with metastatic disease to answer your burning questions. So I really appreciate this. Amy, it was such a pleasure getting to know
Thanks.
you and meeting you virtually. And because you're in New York and I'm in Boston, and we have a lot of friends in the New York area, I definitely would love to come see you in person. So
We'll definitely have to get together in person for
yes.
sure.
Well, thank you, everyone. Have a wonderful evening. And we
Thank
will
you.
log off.